Hi, welcome everyone to this webinar on COVID-19, a conversation with World Health Organization Chief Scientist, Dr. Soumya Swaminathan. I am Asad Islam, the Director for the Center for Development Economics and Sustainability. This webinar is hosted by the CDS at Monash Business School. We are also pleased to have three leading scholars, including two of them are from Monash graduates. They are Monash graduates, Professor Sharon, Lewin, and Dr. Stephen King, and also one of the leading infectious disease expert, Professor Raina Maclntyre. So this is part of our webinar series, COVID-19 and Beyond, to give some a forum for discussion on economic and social issues that are coming up due to this pandemic. We all know that this coronavirus is spreading around the world. In fact, as we speak now, there are 14.6 million cases and almost 610,000 deaths in the world. So it's now clear that until we have a vaccine available that works, we probably will have to live with this virus. And the medical researchers are ramping up efforts to get a vaccine, but we have a vaccine. And vaccine normally takes years to develop, and we are expecting it will happen in months. So this is a big question that we will hear from our guests and the experts. And we also know that government around the world have taken steps to contain the virus. In some cases, they are successful. In many other cases, we see that cases are spreading rapidly. And in few cases, we are now seeing that a virus is coming back. For example, in Melbourne, we see that we were able to contain it, but now we are seeing the virus is back. So we will hear this from our experts, and today's session will have another Q&A session from the audience. So please leave your questions in the Q&A box, and I will now pass to our moderator, Peter Martin. Peter is the business and economic editor of the Conversation, a news outlet that publishes pieces written by mainly academics and researchers. He was a former editor of the economics editor of the newspaper The Age, and economics correspondent of the ABC Radio. And last year, he was made a member of the Order of Australia. Over to you, Peter.
I'm honored to be speaking to this panel. Soumya Swaminathan has only become the chief scientist of the World Health Organization. I think it was toward the end of last year. So the timing, in a sense, couldn't be better, although I suppose anyone would like more preparation for a job like this. Soumya has previously had other roles in the World Health Organization and has 30 years experience in epidemiology, in medicine and in infectious diseases, including HIV. We have three discussants who, after Soumya and I talk, who will join us. Sharon Lewin is the director of the Peter Doherty Institute. She's a leading infectious diseases physician and also has researched HIV. Professor Raina Maclntyre wrote in The Conversation, the news outlet I work for, this morning about masks. Raina heads the Biosecurity program at the Kirby Institute, which conducts research into epidemiology, bioterrorism, all of these things, including mathematical modelling, which are now suddenly important. Dr. Stephen King is a commissioner at the Productivity Commission and has just produced, after I think a longer than 9-month gestation, the inquiry, the final report of the Commission's inquiry into mental health, which will be among the most important reports ever produced by the committee, academic in economics at Monash University. So, Soumya, can I start with you first? Did you have any inkling that this sort of thing was going to happen late last year when you became chief scientist?
Good afternoon, good morning, colleagues. Peter, I'm delighted to be on this webinar with so many distinguished colleagues. And thank you to Gaurav and others for this invitation. Your question is a good one. Did I know, could I even have imagined such a thing would happen? Certainly not. You know, I joined Dr. Tedros's team towards the end of 2017. And at that time, we began what is called the transformation of WHO. So we started thinking about what does it mean for a WHO, fit for purpose WHO in the 21st century? What's worked well? What hasn't worked so well? And what do we need to really change and adapt? And one of the ideas that came out quite strongly was the fact that we needed a science division. Being a science-based agency, a normative standard setting body, we did not have explicitly a focus or a division that focuses on science. And so that was set up, and I was honored to be asked to be the first chief scientist for the World Health Organization. It's been a very interesting 15 months now. And of course, the pandemic was completely unexpected. I think all of us who work in this field knew one day there would be a pandemic. It was a question of when, not if. We all thought it might be an influenza pandemic. We didn't expect necessarily it would be coronavirus. But of course, when it comes, it's a surprise, and it takes everyone, as we've seen over the last few months, that the world has been unprepared for a pandemic of this nature, even though there's been a lot written about how we should have been better prepared. It's been very challenging, and it's been a non-stop, round the clock exercise to keep up with the science. But I think it also proves the need to have had that function, and we're learning as we go along.
Can you give us an update on where we are now? In other words, where it's spreading again, and where it's under control. But because we've only got 20 minutes, I'm looking for an overview.
So very briefly, I think it was mentioned in the introduction, we're still in the exponential phase of this pandemic. It took us, the first 3 months to get to 1 million. Now we're getting to 1 million in every 4 days. In fact, we've had over 250,000 cases now over the last couple of days. So clearly we've entered an exponential phase of growth. And as the DG repeatedly has been saying, things could get much worse before they start getting better. We've seen different patterns. The first one is countries which responded early, responded very fast and quickly, had science-based strategies, had some previous experience perhaps with handling SARS-1 or MERS, and were able to stamp out the infection pretty much. Not to say that they don't still have a few cases or clusters, but very much things under control. We had another set of countries that did well initially, but then things got worse. There were a lot of deaths. Very stringent lockdowns were implemented, and they're now recovering from that and opening up. And we also have a set of countries where things started off perhaps a little bit slow, but have now really grown. What we see today is that the epidemic is very much focused in the Americas, both North and South America. The largest number of the growth is happening there, but you also have countries like India. You have countries in Africa now, South Africa showing increasing numbers. Iran continues to have a growing epidemic, Russia. And then you have cases like Australia, for example, very well under control, but still seeing clusters. It's happened in South Korea, it's happened in Singapore. And I think that's to be expected. And these countries are now prepared and able to meet these. But still, when it happens, it does cause a lot of disruption.
So you don't see it as a, sorry, go on.
The good thing is, I think that deaths have not been increasing exponentially as of cases. But again, deaths there's always a lag between the increase in cases and deaths. But we have seen a sort of stabilization of deaths to about 5,000 a day. It's still far too high, and we can discuss why that may be the case. But it does seem like people are learning to manage this better.
Is there a paradox in India and Victoria in the state of Australia? On the face of it, seem to be an example of this, that there are some countries which have locked down very hard and yet now have a growing second wave or whatever. In other words, I'm wondering whether there are simple lessons to be learnt that or maybe they're not, that a severe lockdown doesn't necessarily guarantee success.
Exactly. So what severe lockdowns do is, of course, they do slow the spread, because you're preventing people from meeting together, and the virus needs this physical person-to-person contact. So it slows it down, but you can't last in lockdown forever. So the moment you open up, you're giving the opportunity for the virus to start spreading again. And so the lockdown, really what it does is gives time for countries to prepare, for local governments and local communities and the health system to prepare for what is indeed going to be a long fight. It's not something that we ever expected a lockdown would be the solution. It's only a temporary pause, really, giving us time. And that's what hopefully many countries have done, but perhaps some haven't. And then those that haven't will continue to see an exponential growth. But those that were able to prepare are with the testing, with the facilities for isolation, quarantine, with the healthcare system needs in terms of PPEs, in terms of manpower, in terms of more beds. Those countries will be able to cope with what is sure to be an increasing number of cases.
We can do that. Australia has had the advantage of building up its ICU capacity during the lockdown. Other countries are not so fortunate because they don't have anything like as good a health infrastructure to start with. Are there different prescriptions that you would give countries with different health systems and different public health systems to start with?
Indeed, I mean, the principles remain the same, Peter, no matter where you are, but then you have to adapt this to local context. In fact, the whole concept of lockdown really doesn't work when you have large urban slums, where lockdowns only put people closer together. You're actually increasing the density of people within some areas. And so what works in Paris or London doesn't necessarily work in Mumbai or Nairobi or in Durban. So definitely you need to think about local context. Also, I think for countries where the health system, the tertiary health system isn't as well developed as it may be in some high income countries, we have to focus more on prevention. We have to focus more on the you may call it upstream, on the community actions that you need, so that you don't actually have that many people needing intensive care. You're still going to need those few ICU beds for those who get sick. But we all know that once you're in an ICU, once you're on a ventilator, the prognosis isn't that good. And so I think if you have limited resources, I would put those resources into the testing, into the detection, into good isolation and quarantine centers, into oxygen, and into community education and mobilization. And we've seen time and time again that local data, local good governance, and local community engagement is what is going to give us results in the long run. And I think initially there was this rush for ventilators, for critical care beds, even in the poorest countries. We need that, but that's not going to be a sustainable solution if we don't address the root.
I've got to ask about vaccine. How long, which is a ridiculous question in a way, because there's never been a vaccine for a coronavirus. So how long might it be? How long might it be? And what are the efforts? As I understand it, it's a multi-track process. That is to say, things which would in the past have happened sequentially are happening at the same time to speed things up.
Yes. So, you know, normally vaccine development takes anything from 5 to 10 years. That's the average time taken by a company to produce a vaccine. And then it could take up to another 10 years, in some cases 20 years, for that vaccine to actually get to people in low-income countries. Now, we don't have that kind of time. I think the previous record is probably the Zika vaccine that was, I think, developed within a matter of 2 years. The Ebola vaccine took about 5 years because, of course, you know, there wasn't an epidemic between 2014 and 2018. So here we're trying to accelerate it, and this is why we set up what's called the ACT Accelerator, which is the Access to COVID Technologies. And this was launched by WHO along with the Gates Foundation, or rather Melinda Gates herself, on their behalf, with the President of the European Commission and President Macron from France, on April 24th, to bring together both global agencies, governments, both high-income, low-income, middle-income governments, so the whole world really, the private sector, because you need the private sector to develop the vaccines, in order to accelerate the development of diagnostics, therapeutics, and vaccines. And what we've accomplished in the last 8 weeks, I think, is remarkable. We've had all of these agencies come together. So for vaccines, the pillar of vaccines, for example, is WHO working with CEPI and Gavi. CEPI was set up, as you know, in 2016 to the post-Ebola outbreak in order to develop vaccines for these diseases of pandemic potential. So they were exactly set up to develop a vaccine for something like this. And what they've invested in over the last couple of years has been platform technologies. They've invested in biotech companies. The RNA vaccine, for example, that Moderna is developing, the early grants came from CEPI. And so we've been able to, because of technology and because the genetic sequence was available on January 11th of this SARS-CoV-2, very quickly, over 200 vaccine candidates in development. Of course, we still need to go through the process of the clinical development. And so today we see 23 candidates in anywhere from phase 1 to phase 3, so in human clinical trials. That's a remarkable achievement if you think about the fact that we've only known of this virus for 6 months. And we have a couple of vaccines entering phase 3. So by the end of this year, we should have some results. And if they are positive, and let's hope they are, we could think about having vaccines for human use in the first half of 2021. We have to keep in mind that we will have limited doses. We may have doses in the ranges of hundreds of millions if we're lucky. And therefore, we also need to think about equitable distribution and fair allocation of these vaccines. We don't want to be in a situation where a few high-income countries have vaccines for their populations, or the rest of the world is left behind waiting. And so WHO is really working with countries now to think about the fair allocation mechanism and framework that would go hand in hand with the availability of vaccines. And then later on beyond 2021, we might then start seeing larger volumes available, which will mean that countries will be able to vaccinate larger groups of people in their countries. But initially, we really need to think seriously about how to prioritize who will be those groups of people who should get the vaccine first across countries.
How will you do that? The COVAX facility is one of the things that you're setting up to try and ensure that the US or the country that develops the vaccine or the countries with resources don't get all of it.
So the idea is that you have a COVAX facility, which is a pooling mechanism. So it pools two things. It pools risk, because any country investing in one vaccine is taking a big chance. Because if that vaccine doesn't work, then that country doesn't really have access. So by putting money into a common pot and allowing CEPI to invest in a wide variety of vaccine candidates, and in investing in at-risk manufacturing, also distributed, you have a better chance of getting a winner. The other thing that you're pooling is you're pooling the procurement, and therefore you're increasing your chances of getting a better price for the vaccine, because a pooled procurement is always going to be more cost effective. Now, there are two kinds of countries that would be in the COVAX facility. They're the self-financing countries that are expected to buy the vaccine. And it's, we don't know what the vaccine is going to cost, but most of the companies have promised that they would provide it at a not-for-profit cost. But it could still be a tiered pricing. So you may have one price for high-income countries, one price for middle income, and one price for the low-income countries. So if the self-financing countries, their large numbers, invest in this COVAX facility and are willing to pay a little bit upfront, maybe 15 or 20%, and the rest at the time they buy their vaccine, that gives CEPI, Gavi, WHO some resources to invest now, because you need to invest now in manufacturing and in R&D. And then you have the countries which are the Gavi, traditional Gavi countries, plus the small islands. So these are about 90 countries that would avail of the vaccine as the beneficiary countries from the COVAX facility. And when you look at high income and upper middle income countries on the one hand, and the low and low middle income countries on the other hand, they're actually very equally balanced in terms of population. So about 3.8 billion each. And so this seems like it would be a good way. And the other major principle here, Peter, is that all these countries in the COVAX facility agree that as the vaccine doses become available, they would be willing to accept tranches to cover a certain percentage of their population. So let's say you had 200 million doses. You would distribute that across all countries to cover 3% of their population initially, up to 3%. Those could be frontline workers, for example, health workers, social care workers, and others who are at high risk. And then the next tranche would cover up to 20% of their population. That would be the floor. And then, of course, you go over and over. But the basic principle that everyone would need to accept is that initially, everyone gets an equal allocation, regardless of whether you're self-financing or whether you're getting it from Gavi because you're a low-income country.
Can I ask,
that's where the...
Do we know which high-income countries have agreed to take part? Is Australia one of them? Is the US one of them? Is Europe?
Australia is, the US is not, the United Kingdom is, several high-income countries in Europe have signed up, the Middle East, also from Asia and Africa. Now, the way it works is that there's been an expression of interest that these countries, there are 75 of them now that have expressed an interest in this, the self-financing part of it. Now, we had last week sessions for each of these countries, for all the 75 countries to take part in a question and answer session as to how exactly this would work. Because obviously countries have a lot of questions about how the COVAX facility will work, how will it be governed, what are the timelines like, when do you have to invest? So we answered a lot of those questions. And this week we have a similar set of sessions for the Gavi eligible countries. By August 31st is the deadline for countries to actually make the payments and have the non-binding, rather the binding commitments into the COVAX facility. And the idea is, as I said, to create a pool of resources which can then go into financing the R&D of, currently there are 9 candidates in the CEPI portfolio, but the COVAX facility is open to all vaccines, whether or not they've been funded by CEPI. So many of the multinationals we know, the Janssen and Sanofi and Pfizer and all of these big companies have candidates in the pipeline. And so the COVAX facility would purchase, based on some criteria, of course, the vaccines have to meet some eligibility criteria of having demonstrated efficacy and safety and having passed the bar of the WHO criteria that have been set. And so this would be a process that would probably go through 2021 into 2022. But end of August is when we're looking at having those commitments from the self-financing countries.
Is part of the idea that the drugs, vaccines, potential vaccines will be manufactured before they are approved?
Yes.
To speed things up. Yeah.
Exactly.
So vaccines is one thing, treatments is another. What do we know now? There's a number of drugs that people are talking about which are already used to treat other things.
So treatments is where there's been a lot of movement, because even at the beginning, you had the Chinese researchers doing clinical trials for many of the repurposed drugs. And this has been followed up. In fact, we're tracking about 4,000 clinical trials now. So I should just say this has been a problem as well as a good thing, because we've had too many small trials, I should say, which are inconclusive. So one of the lessons we've learned is you need large, good quality, randomized trials to answer these questions. But having said that, what we do know now, hydroxychloroquine does not work in hospitalized patients with moderate or severe COVID. Lopinavir, ritonavir, another anti-HIV drug, repurposed, does not work. What does seem to have some effect, and we don't know fully what effect it has, is remdesivir. Again, a repurposed drug was developed for Ebola as an RNA polymerase inhibitor. Has shown to reduce the days of hospitalization, but has not been shown really to reduce mortality among COVID patients. Is not really widely accessible so far, even though there are some generic manufacturers now that have been giving the license. We've learned that dexamethasone, a cheap, generic, widely available steroid, does reduce mortality in patients who are severe or critically ill, that is those who are on respiratory support. And the next frontier now is really looking at monoclonal antibodies, several of which have gone into clinical trials, both as a preventive, but also perhaps for early treatment. And
what
because
do
we
know?
understand because we understand the pathogenesis better now, we know that antivirals will probably work much better if they're given earlier in the course of disease, anti-inflammatory and immune modulators during the later part of the disease, antithrombotics. So they're really these three classes of antivirals, immunomodulators, antithrombotics that are now being tested singly or in combination. So I think we've obviously learned how to treat this disease better. As I said, the mortality rates generally are much lower now than they were in the earlier part of the pandemic, but we need to do better.
What do we know about the disease itself protecting people, about whether or not you can get immunity, how long it lasts?
That's a good question, and that's something we're really learning, I think, on a daily basis. And I'm sure Sharon and others would be tracking this as well. What we do know is that most people who recover do develop antibodies. You can detect neutralizing antibodies, the majority of them. The ones who have severe illness seem to have a higher titer of antibodies. How long does it last? This is still an open question. We also know now that people have cell-mediated immune responses as well, which is really good. And again, it's one of those things as we are learning. But I think overall, I would say that what we know now is enough to give us some optimism that a vaccine could be developed, because natural infection does result in some kind of immunity. Again, how long lasting, we don't know. But a vaccine that induces both T-cell responses and neutralizing antibody responses would probably be a good one to test.
Realistically, we're going to have to, for what you've said, wait a long time before, just even on the amount of vaccine drugs available, should the quantum of vaccine available, should a vaccine work, we're going to have to wait a long time until enough of the population is immunized for it to work. In the meantime, what do we know about aerosol transmission and masks? And I think this has changed. That is, the dominant view has changed.
So we've known from the beginning that this virus is one that's spread from person to person by droplets. We've known that from other coronaviruses as well, and of course other respiratory viruses. Now, what we've learned now is that two things, I would say. One, that people who are not symptomatic can also be infectious, and particularly those who are just in the day or two before they develop symptoms, so what we call the pre-symptomatic phase. People do have a high viral load in their respiratory tract at that time, and so they could be infectious. Some people who are completely asymptomatic themselves could also spread the infection, though what we have seen from cohort studies is that that proportion is much lower than those who develop symptoms. So while asymptomatic people can spread the infection to others, they seem to do so less than those who have symptoms. Now, The other thing that we've learned, of course, is that the respiratory droplets come of all sizes. And while the majority of transmission is happening from person to person through the classical route of respiratory droplets, which are greater than 5 microns, which are larger droplets, and therefore they fall to the ground within a couple of feet of the individual. So you need close, prolonged contact between people in order for this transmission to happen. And this is where masks really play a big role, because they prevent these droplets from coming out, and even ordinary fabric masks have been found to be quite effective. So where you don't have that physical distancing, wearing a mask really cuts down. And if both people are wearing masks, it helps to cut down this droplet transmission. Now, the small droplets or the aerosols, again, there have been a lot of studies done recently which have shown that you can generate these when you're speaking loudly, when you're laughing, when you're singing, etc. And that these smaller particles, which are less than 5 microns, can stay in the air. They can float in the air for some time. We still don't know, maybe 30 minutes, maybe an hour. And if you're in an environment which is a closed environment, where there are several people within a room without good ventilation, you could be in a situation where these small particles in that room, you could be breathing them in, and you could therefore get exposed.
Even if the people are nowhere near you, even if the people are 2 meters away.
Even if they're beyond 2 meters, yes, even if they're beyond 2 meters, because these particles could travel and could hang around in that air. And again, it's special settings we've seen this happen. We've seen it happen in these meat factories. We've seen it happen in nightclubs where people are close together, where they're talking loudly, and where, again, prolonged contact in that closed space. A couple of restaurants, call centers. Of course, the migrant labor dormitories that we've seen in Germany, in the Middle East, where a lot of people are sharing that space, and where there may be 1 or 2 people who are highly infectious. The other interesting thing we've learned, Peter, is that a few people with high viral load seem to account for a large majority of the infections. And this has come up repeatedly in many publications now. It's not everyone is equally infectious. So if by chance you have a person who's highly infectious in this closed setting, that's where you get a super spreader event. And many of these have now been described. So these are the things we've learned, and that's why the guidance on masks has changed from first talking about masking for those who are symptomatic or those who are caring for ill people. In the beginning, of course, we also wanted to save masks for the health workers because there was such a global shortage of masks. And so we needed to make sure the health workers and the frontline workers had these PPEs. But now that we know that in many parts of the world, physical distancing is impossible, and that the droplets could still infect you if you don't have that physical distancing, masking up is probably a good way, a simple and a cheap way of stopping at least a proportion of that droplet transmission, if not the entire amount.
Well, now we should open it up to the other panelists. Sharon Lewin, you may have a question or a comment to make. Unmute.
Yes, spend all my life on Zoom and forget to unmute. Thanks very much, Peter, and thank you so much, Soumya. It's been fabulous to hear from you. Given I'm speaking to the chief scientist of the biggest health organisation in the world, I'm not going to ask you a scientific question. I'd like to ask you, how do you think the world will be different post-COVID-19, particularly in the aspects of global and public health, and what opportunities might we have from such a crisis to make the world a better place?
That's a great question, Sharon, and I think we should all introspect on that. I do hope a couple of things will change. One, that the world collaborates more in terms of sharing of data, sharing knowledge, sharing resources. I mean, we've seen incredible collaboration between scientists. We've been convening scientists and researchers right from the beginning of this pandemic. And the willingness to share, the willingness to learn, the willingness to help has been amazing. And I hope that spirit continues. The journals have all opened up and, have gotten rid of their paywalls as far as this is concerned. Product development is the other area where I hope that we can continue to see this kind of collaboration. It's been a market-driven approach so far, and that's why we've not seen products for neglected diseases. You and I have worked on tuberculosis and HIV, and we've struggled to see investments in drugs and vaccines for tuberculosis, for example. So I hope that changes. And then I hope that we also rethink the way we live our lives, all of us, whether we're scientists or just citizens, in terms of caring for the environment, trying to be more conscious of our own carbon footprints in how we work and travel. And, you know, we're doing this now through Zoom. Can we continue to do a lot of our work without actually having to hop on a plane and travel for a few hours of a meeting? So, but I think the biggest change I would like, and then I would say finally, is an appreciation of science by the general public. I think we've got this enormous interest in science now. Never before has it happened. And it's had its good side, but it's also had downsides, because there's been also this misinformation campaign by people who twist facts and confuse people. And so I think we've got this huge opportunity now to get an interest in the average general citizens of the world to follow scientific advice and knowledge, and to be able to distinguish between misinformation. It's tough sometimes because of the way they do it so cleverly, it's twisted, but to be able to ask the right questions. And we see this happening, I think, in country after country, and media has played a big role in this as well. And I hope that we can inculcate in the younger generation as well an interest in going into science in general, which I think was going down over the last few years.
Raina, do you have, Raina Maclntyre, if you can unmute, do you have a question or a comment?
Yes, thank you very much, Soumya. That was a really fantastic overview of a very wide range of issues that are concerning everyone. I had two questions, if I may. One was touching on the issue we discussed earlier about vaccines and how we get vaccines to everyone equitably. Given that it's likely that we will have short supply initially, and countries may only have enough for their first responders, which won't really impact epidemic control. Have you thought about lessons from smallpox? And, you know, in that case, the initial goal was a mass vaccination, but there were a few hotspots in the world, including India, where it was mass vaccination just wasn't achievable. And so they switched to a ring vaccination strategy. And is that something that WHO is thinking about, you know, whether to use like a ring vaccination strategy on the assumption that exposed contacts, there may be some efficacy of the vaccine in exposed contacts? And the second question was about human challenge studies. So I know that WHO has discussed the idea of trying to expedite the vaccine trials by using human challenge studies where, you know, people are infected deliberately and to see the effect of vaccines. What do you think about the ethical challenges around such an approach, and particularly, you know, if those kind of studies, if they do happen, if they end up being in low-income countries with more vulnerable people who may be exploited in the conduct of such research?
Thank you, Raina. Those are excellent questions. So the first one about ring vaccination, indeed, we have been discussing the various strategies and options for how one might want to vaccinate. Given the initial shortage of vaccines, we see that there is going to be limited supplies. So we have, of course, the SAGE, which is the Scientific Advisory Group of Experts on Immunization, which makes policy on immunization for the world. And they've set up a working group on COVID vaccines that started deliberating now, listening to experts from around the world, thinking about the strategy and the policies. Specific policies, of course, will be made once you have a specific vaccine with certain characteristics. But I think they are considering the approaches for vaccination and what might give you the most benefit in terms of reducing mortality, in terms of interrupting transmission. You know, what should countries be weighing? And the ring vaccination campaign we've done it for smallpox, as you said, more recently for Ebola, very successfully in the DRC. It depends, of course, on how quickly you can identify contacts and how quickly the immunity develops after giving the vaccine. So when WHO put out a target product profile for this vaccine, we had two scenarios. One was a scenario of outbreak control, and the other was a scenario of prevention, more long-term prevention. And so there are different characteristics for these two kinds of vaccines. And in fact, in the COVAX facility, one of the things we have decided is to set aside a proportion of the doses, whatever the doses may be, 5 to 10% to be kept aside for humanitarian use. And those could be things like a migrant camp or some other big outbreak in a very densely populated area. So I don't have an answer for whether or not this approach is going to be used, but yes, it's definitely one of the options on the table. The other question about human challenge studies, also what we did quite early on was to bring scientists and ethicists together to think about when would you want to think about human challenge studies, what kind of situations, what would be the ethical issues and the ethical framework in which this should be done, and what would be the operational issues that you would need to address. There are very technical issues like the strain of the virus, the actual dose of the virus, how do you, that has to be made under GMP conditions for a clinical trial, and then it has to be administered in a particular way. You need those infection control BSL settings where you would do the challenge, etc. But on the ethical side, I think is what is more tricky. The operational scientific side, I think, can be, I'm sure they'll be figured it out. On the ethical side, we put out a framework that researchers really want to look at and very carefully consider, particularly in this situation where there's no curative treatment yet for this infection. Of course, you have now remdesivir, which might help to some extent, but there's still no definitive cure. And in that setting, you are asking people to take a risk, even if it's very low risk for a young, healthy adult. The risk, nevertheless, is not negligible.
And it's true, by the way, that the risk extends to more than what we thought. That is to say, it extends to other parts of the body.
Exactly.
And the effects over a long time for a volunteer are completely unknown, of course.
And so you'd have to proceed extremely carefully. You'd have to ensure that you've done everything to minimize risk, but also that the volunteers fully understand what they're getting into and what the consequences could be. And so we have two sets of documents. We have a document which looks at the ethical issues that's been developed by this global group of bioethicists. And there's another document that lays out the operational issues. There are a couple of countries that are now considering this, but it would have to be done very carefully in a place where you have everything set up to provide the maximum safety to the participants and of course to the researchers. So wouldn't be something one would do in a low-income setting at all in the first instance.
Our final discussant is Stephen King, who's the only economist in the room.
Thanks, Peter, and thanks, Soumya, for a really interesting overview. I'm unsurprisingly going to ask you just a couple of questions on the economic side more. So my take is that, pre-vaccine, until a vaccine comes along, certainly most developed countries are going to be in a situation of managing the infection rate, unless they're in the privileged position of being an isolated island like New Zealand. There's going to be an ongoing rate of infection, and it may be able to be kept at 100 to 200 infections a day, which hopefully is manageable. But at the same time, we've seen pressures in countries trying to do that, to ease up restrictions, remove social distancing requirements, remove mask requirements. So my first question is, have you got any advice to those countries of how they avoid a yo-yo effect of the virus essentially getting out of control again, having to have a hard lockdown with all its costs, both health costs and economic costs, easing up again and so on. So that's my first question. Any thoughts on that? The second one is, how do we learn from this for the future? So slightly different to Sharon. Sharon said, well, how will the world look different? What I want to ask is, how do we actually embed the learning from this? How do we make sure that we don't, in 15 years' time, have forgotten about all of the lessons from this, have forgotten the policy lessons, the need to make sure that we have a resilience in society, and then have another pandemic, perhaps in 15, 30, however many years. I mean, another one's inevitable. So they're my two questions.
Thanks, Stephen. I'm not sure I have good answers for both these excellent questions. For the second one, I would say that we need to do what we should have been doing all along, which is preparing for a pandemic. And there have been, you know, any number of reports and commissions and groups that have warned the world about a future pandemic and what countries must do. And of course, we don't take it seriously because it's investments in preparedness. The other interesting thing is the Global Health Security Initiative, you know, last year did an exercise where they graded countries on their preparedness. And lo and behold, the countries that had the highest score are the ones who've seen the worst outbreaks. Okay, so, you know, the US, the UK, all had very high scores on their Global Health Security Index. And of course, the low-income countries had low scores. But what you're seeing is a reverse now, with the worst outbreaks in these high, at least up to now. Things could change, of course. We hope not. And the low-income countries in Africa, which are traditionally, I think, have invested more in primary health, in their public health system, even though they may have fewer doctors, fewer tertiary care centers, because of the HIV, you know, epidemic. They have actually invested in community health workers, in those outreaches, in community mobilization, in nurses that are close to their communities. And perhaps that's something that's helped them, despite the fact that, you know, the diagnostic testing and all that was very hard for them. So I think we need to rethink where the investments need to be. High-income countries also have to think about where things went wrong. There was no public health cadre left in many of these countries. Now they've had to hire contact tracers. They've had to hire a whole new workforce of people. So, and for countries like India, for example, I think investing in primary healthcare, investing in data systems, in good surveillance, in making sure you have trained epidemiologists, not just in the capital cities, but out in the districts and sub-district levels, in having a system for early alertness. So the WHO last year, when we developed our 5-year strategic plan, one of the things we said was we had 3 pillars: universal health coverage, the emergency pillar for protection from outbreaks and emergencies, and the healthy lives pillar, which looks at, you know, all the other policies and actions you need. So the emergencies pillar is really about prevention and risk detection and response. So we have to look at all the 3. How do you prevent? Do you have systems to prevent some things from happening? Last year, we had the Nipah outbreak in Kerala state in India. It was nipped in the bud. And, you know, it could easily have spun out of control. But because Kerala state has such a good public health system, they were able to prevent, detect, respond in a timely manner. And so I think all countries, big or small, high or low income, need to think about, are these systems fit for purpose and are they up and running? And, you know, investments in prevention always are much less attractive to politicians than investment in big hospitals or in infrastructure. So there needs to be a shift there. And then talking about, coming back to your previous question about what lessons can countries learn, again, I think it's being adaptive, it's being responsive to local situations. We've seen that just copying something that some other country didn't work, but there are many lessons now that we've different models. We've seen what Vietnam did. We've seen what South Korea did. Their focus was on diagnostics, just scaling up diagnostics. What Germany did, again, focusing on diagnostics, on technology. But community involvement, I think, is such an important element. Taiwan did well very early on because the people there, having lived through SARS, knew that the moment the government tells them to do, X, Y, and Z, they were willing to cooperate, including with things like sharing their mobile data and so on in the greater public good. And so I think the trust building and the communication with people is an extremely important element. And we've seen those countries where that communication from leadership, there's been good political, strong leadership, good governance, clear messaging has made a big difference.
Listening to you, I keep thinking of one country, which is the US, which is almost an exception because it's a country with high income, high standard of living, and yet a low trust in government. And we might be seeing whereas Australia also has a high standard of living that has a high trust in government. That may be reflected. We've got some questions from the audience. We'll probably only get to two or three of them. I'll ask this question, and then after you answer it, Soumya, it may be that other panelists want to join in and raise other things, and I'll put some other questions in as well. One is that the question is that infections seem to be growing exponentially, but deaths are increasing in only a linear fashion. I'm not sure if that maths is correct, but it does tend to suggest, the questioner asks, that the disease is becoming less potent or less fatal as time goes on. Is that right? And I may have spoken too fast for you there. I'm sorry if I have.
No, I think the conclusion that the disease is becoming less virulent is not correct. There's absolutely no evidence that the virus has mutated to be less virulent. In fact, there's some thinking about a particular mutation that might actually cause this virus to be more transmissible. What has changed is that a couple of things. One, we've learned more about how to manage this. And so the experience from China, from Italy, from the UK has now given us a lot of information about how to triage risk and how to manage those who are at different stages of the illness, and particularly how to manage people who end up in critical care. So that's, I think, there's also been time for doctors and nurses and critical care setups to get more prepared. Again, I'm talking about high income settings. This is not so relevant for low income settings. The other thing is that I think testing has increased a lot. And so when you calculate case fatality rate, which is a 1-point calculation of deaths divided by the number of cases that you know at that point of time to be infected, it's a little bit varies from place to place, depending on how much you're testing, how well your reporting is. We know death reporting isn't also very accurate in many countries, and that many countries have had to then go back and recount and correct their actual death figures. What's, I think, more accurate is the infection fatality ratio, which is now estimated to be, it's under 1% for sure, somewhere in the range of 0.6 to 0.7. So if you take the total number of infected, and which we know from the seroprevalence studies that have been done in many countries, that the number of people infected is far, far higher than the number who are actually diagnosed by the testing that's available. Then the death rate is much lower. But even that, I think these figures will be updated as we go along. So I think that there are many reasons why deaths are not increasing as high as infections are, and a lot has to do with diagnosing, and many of those being diagnosed have mild illness. In the US, for example, a large proportion of those diagnosed in the last month have been younger people in their early 30s that we know are at much lower risk of death. But that's not to say that eventually it will not catch up, because deaths do lag behind. And of course, in many places, all deaths due to COVID are not yet being counted because of a number of reasons. But we hope that improving management practices has also something to do with keeping the deaths low.
I'll open it up to the other panelists. And Sharon, you only got one question in first, so you may have another one.
Oh, another question. All right, I'm going to ask another non-scientific question. Soumya, there's been a lot of discussion about, you probably will hate this question, but I'm going to ask it. There's been a lot of discussion about women in leadership roles in the response, and how several countries led by women, Taiwan, Germany, New Zealand, have done well. you want to reflect on that and perhaps your own experience as well as a woman in a very significant leadership role globally?
Well, yes, I mean, it's interesting to see those reports, and of course, I don't think there's any statistical analysis that's been done looking at women leaders versus male leaders. But like I said before, I think the main elements of good leadership that we've seen have been taking it seriously right from the beginning, having a science-based, a data-based approach. And so when you have leaders who themselves are scientists, I think Chancellor Merkel is a good example of somebody who has really relied on her scientific institutions and has always stood by the advice given by scientists. And many other countries have done the same. Those who have, where there's already been a good trusting relationship between government and people, but who've been able to maintain that. Those who've communicated well and have given messages of, based again on evidence and science, but also messages that resonate with the communities, giving them some hope. I think those leaders have done well, and I can think of several male and female leaders who've done a very good job of this. But I think those are the main elements really. And it's been a tough time for political leaders because also the science has been evolving and changing. And one has had to keep this balance between not sounding like you're going back on something you said. And we've had that challenge as well from the WHO, because people say, why did you change your guidance? And well, the guidance has to change and adapt to the evolving knowledge base. And we try and update it.
That's actually one of these, sorry, that's one of the questions that we have here, which is why didn't the WHO from the beginning adopt the precautionary principle? You've answered some of that by saying that, well, for masks, there were good reasons for not suggesting everyone get them because there was a shortage. And why you're answering the other part of it now, because the evidence has changed. Do you think that the WHO was precautionary enough in its advice at the beginning?
You've frozen, Peter.
Say that the was the WHO precautionary enough at the beginning? It's okay if.
I think WHO did the best it could, and it's always easy, of course, in retrospect, to think that we could have done better. I'm sure we could have, and there are lessons to be learned, I think, for everyone from this, including the WHO, on how one could do better. Our guidance is all made by expert advisory groups that are created from experts from around the world. That's how our guidance is normally done. And it goes through this quality assurance process. So in normal times, a guideline would take something like a minimum of 6 to 9 months to go through that process of meta-analysis, evidence synthesis, getting the guideline development group together, and then taking it through the quality assurance process and so on. We've now contracted that time so that a guidance can come out in say under 2 weeks, or sometimes in even less time if it's a real emergency situation, and yet build on the same principles of what's the evidence base, do the meta-analysis, do the evidence synthesis, get together the expert advisory group, which is usually diverse in terms of geography, gender, and disciplines, and get them to agree on the guidance that's needed. And that's the same thing that's happened now, that we've followed up with the same principles, and this takes time. So again, they also look at the balance between it's the scientific evidence and data, but it's also looking at things like equity, ethics, and the harms from some of these things. So, for example, just as an example, if you say everyone should wear N95 masks. Okay, now there are risks also to N95 masks. And so there's an evidence synthesis that was done to show what are the benefits, what are the risks, and then decide which group of people would the benefits outweigh the risks. And it doesn't do that for the general population at all. Whereas it does do it for healthcare workers who are exposed to a lot of infection in healthcare settings. And so for each question that is raised, there is this element of balancing. And then of course you have the evidence base itself is very weak in this case. Now, of course, it's growing. We're learning more and more. So in the beginning, we had to go from experience with other coronaviruses or other respiratory viruses and studies that have been done in those settings to try and extrapolate to this one.
The harshest political criticism that has been made is that the WHO was overly keen not to offend China. That's the most brutal criticism. I have no idea whether that's true. You might.
Not at all. You know, for WHO, all member states are the same, and people perhaps don't realize what powers the WHO has and what it doesn't. WHO is an agency that works through consensus building. It's made up of the 194 member states. And so the WHO officers themselves, all of us are basically in the secretariat, but we are guided by the 194 member states through the executive board and through the assembly. And so the powers that they give us is what is the powers that we have. So for example, we do not have the powers to march into countries and start inspecting facilities, for example. So we depend on data that countries give us. We depend on this process of a dialogue, which encourages countries to do the best. And of course, we can make statements, we can make guidelines, we can say these are but there are the international health regulations, which all these member states have signed up to, is what, and it's a binding regulation, is what every country is guided by and is meant to follow the rules on. But again, it's voluntary, and there is we don't have the authority to take any kind of action. There's been a lot of discussion now on whether WHO should be strengthened and whether these kind of powers be invested. But again, it's for member states. They're the ones who are going to have to decide. They're the ones who are going to have to implement if they think that that's the best way forward. And perhaps that's one of the things that will come out of this pandemic, is a good discussion on the roles and the responsibilities and the powers of WHO.
We should wrap up in 5 minutes at 10 past. I'll ask each of the panelists, we've just heard from you, Sharon, so I'll ask Raina first, then Stephen, then Sharon, for any final comments or observations, and then you can close, Soumya. Raina.
I guess, from what I've heard from Soumya and from what I've from following what's going on, I think there is hope that we will have, more than one vaccine candidate that will be good enough. We may not have perfect vaccines, and I think it's also really hopeful that WHO has this strategy to try and ensure equitable, access to vaccines around the world, because in the end, we have to control the disease everywhere for it to be controlled in any country. As we've seen in Australia, through return travellers, one return traveller who infected someone in a hotel quarantine setting has set off this terrible situation in Victoria. So we really do need to control it in the whole world.
Stephen.
Yeah, thanks, Peter. I guess one of the takeaways, Soumya, from what you've said is that issue of different strategies in different countries. And I noticed one of the questions mentioned Dharavi, which is a large slum in Bombay. And how can you have social distancing there? And I think what we've seen from India's attempt to shut down is you can't. It's quite simple. I guess my final comment, though, is that I think sometimes governments need to follow the scientific evidence, but they also need to recognise their own limitations. People's behaviour changes because of a virus. So when COVID-19 started infecting societies, we saw people's behaviour change actually before government started introducing policies. People started, particularly the elderly, started actually self-isolating. So governments can help that process. I think governments need to see themselves as facilitators rather than saying, well, here's a strict, strong set of rules. And because I think what we've seen in the US is that when they do sometimes end up in this political fight over strong policies, it can actually have negative consequences rather than positive. So I'll leave it there.
Sharon.
Yeah, thanks, Peter. When you introduced me, you mentioned that my background is in HIV, which it is as a clinician and scientist. But in HIV, there was sort of three parts of the effective response to HIV, and it was leadership, science, and community. And I think with the discussions today, we sort of saw how leadership and how that's varied and what's good and what hasn't been good leadership. I think we should be, really proud of the role that science has played and its value that people see, and the speed at which science has moved has been extraordinary. But I do think the last pillar about community is something we haven't quite yet optimised, especially even in Australia. I mean, Soumya spoke about areas of the world where community-led responses have actually, shown some benefit. And we've had these very top-down responses, the government locking things down, police enforcing mask wearing. And this is where, we're seeing this in Australia. And I just think we need to do, and then also all these vulnerable communities being infected by COVID-19, even in a country like Australia. So we need that community leadership, and we need to really elevate their voice. I think we haven't yet seen, even in a country like Australia, which has a vibrant democracy, we really haven't seen that. And so I hope that's what we'll see more, because that's what I think will be sustainable.
Soumya, there's a number of points to respond to there. I'll just add one more, which is the question of how long is your guess that it will be before we can act as we did before? How long before there is international travel and all of those other things? It's a big question, I know, but your chance to finish up.
The last time, when someone asked me that question, it was a Financial Times webinar, and I said, oh, it could be 3 or 4 or 5 years. The headline actually on the front pages of the Financial Times was Chief Scientist of WHO takes a very bleak view and says it could be 5 years before we get back to normal. So I had everyone messaging me saying, why did you take such a bleak view? No, I think we can be quite optimistic about vaccines just because of the amount of effort that's going into it. I do hope we have not one, but several effective vaccines, whether this is going to be a once in a lifetime vaccine or one that we have to take every year, like a flu vaccine, we still don't know. But let's hope we get one that's safe and efficacious. And if we do, then like I said, by 2022, we should have enough vaccines to protect enough of the world to generate that herd immunity that everyone's been discussing in order to prevent this kind of transmission at least and bring an end to what we call the acute phase of the pandemic. But for the next year, year and a half, I think things are going to be tough. We're going to have to maintain this level of being on high alert. And one thing I do worry about is the impact on other health services, particularly on chronic diseases, on mental health. We've had several modeling exercises that have looked at HIV, that have looked at TB and malaria, and have projected that the absolutely detrimental effects of this, both because attention has been taken away from these diseases, health centers are not able to deliver those services, that investments are perhaps would also suffer, and supply chain disruptions have resulted in shortages of drugs and of bed nets and so on. So we also hear a lot about mental health impact. I think all of our mental health has been affected in these last few months, and particularly for people who already have mental health issues. I think it's been very difficult, for the elderly, people feeling more isolated. And so there's a greater need than ever before for mental health services. And for all the other services, immunization has suffered around the world. And we've already seen measles, the last couple of years have seen increasing measles cases around the world because of other reasons. And I just hope we don't see more of those outbreaks this year. So our SDG goals, for many of the goals, we're going to see setbacks happening in all the progress that we've made. We know that hunger is going to increase this year, that livelihoods have been lost. So there are a lot of things which beyond COVID that we need to think about. But I do hope that when we think about these, that we think about sustainable solutions that are good for the environment and good for people and good for lives and livelihoods. And that we do things in a more thoughtful way. And most importantly, and maybe my final point would be about not leaving people behind, because we've seen with the digital world that we're living in now, that all of us are able to do this because we have access to wireless and internet and so on. But there are large parts of the world still which don't. I'm thinking about children out of school who do not have the opportunity for online learning. And so again, there's this potential to create a digital divide and exacerbate all of these inequalities through a new inequality of a digital one. And so I hope that investments will be made now by governments in connectivity so that these amazing advances that have happened over the last few months, where a lot of technology is being used also for healthcare delivery, that it doesn't exclude those who are the most vulnerable and the most hard to reach in any case. Thank you very much.
It would be great if something like that came out of it. Thank you, Soumya. Thank you, Sharon. Thank you, Raina. And thank you, Steve.
Thank you. Bye-bye.
Thank you, everybody, for attending this webinar. A video record will be available on our website as Center for Development Economics and Sustainability website. You can visit tomorrow or any time later. Thank you to all audiences, and thanks very much to our main guest, Soumya, and to our panelists, Sharon, Raina, and Stephen. And thank you, Peter. On behalf of CDS, we thank you very much, and we hope you all stay safe and well, and good luck to everybody. Thank you.